I would like to take this opportunity to welcome Dr. Nils Becker, who's from Boston, so he's seen this stuff before. Nils comes to us via a circuitous route after obtaining his MD and completing his dissertation in Germany. He pursued some research in Texas and discovered pathology. He was working on skin and shifted from his original career path of plastic surgery to pathology. Nils completed a residency in APCP at a small institution in St. Louis, Washington University in St. Louis, and is currently serving as a dermatopathology fellow at Tufts University School of Medicine. He has done some research in the area of melanoma and will be speaking to us on molecular pathways in cutaneous melanoma. Thank you, Nils.
Well, thank you very much, and thank you very much for the invitation. I'm trying to cover a relatively broad field in this talk, and I understand that the audience is very diverse, so I'm trying to give everyone kind of an introduction into everything, and at the same time trying not to bore people who are into this field. So I have no conflicts of interest, and in general my talk is composed of 4 parts. The first one is to give everyone an introduction to melanoma, then what type of molecular diagnostic aids we currently have, the molecular pathways that are implicated in cutaneous melanomas in particular, and what current targeted therapies are available and under investigation. Now, in general, melanoma is, this is for the non-AP people, melanoma is not equal melanoma. There are several types of melanoma. The WHO classifies the main subtypes as superficial spreading melanoma, nodular melanoma, and lentigo-malignant melanoma. And I added acral lentiginous melanoma here as well because it's kind of a different subcategory as well. Now on top of that, there are numerous variants, including desmoplastic melanoma, spindle cell melanoma, and so forth. Just to give you an idea that we're not talking about a single entity per se in that sense. There's a different way of looking at the classification scheme as well, and this is mainly in non-glabrous skin. So non-glabrous skin is hair-bearing skin. And you can basically divide that into melanomas that occur in non-chronically sun-damaged skin, and those are characterized by frequent BRAF mutations, and they usually don't show KIT mutations. At the same time, chronically sun-damaged skin usually shows infrequent BRAF mutations and KIT mutations in approximately 20%. And if you remember the acral melanomas that I mentioned on the slide before, those actually show mutations or amplifications of KIT in about 40%. Now, generally, melanoma in the US has a very high prevalence, about 80,000 new cases in 2013. That comprises about 5% of all new cancer cases. And the estimated deaths are close to 10,000 per year. That is about 1.6% of all cancer-related deaths. Interestingly, and this is a worldwide phenomenon, the incidence of melanoma has increased quite a bit over the past decades, and it's not quite clear whether that is just because of different habits, if there's an increased rate of detection because things get biopsied more, or called more. However, if you notice here, actually, the deaths has not significantly changed really over the past 30 years. If you look at the melanomas in the US, about 84% are localized. About 10% are regional, meaning they develop local lymph node metastasis or in-transit mets, and about 4% are distant mets, and 4% are unknown. Now, interestingly, the 5-year survival depends greatly on the stage. If you look at localized melanomas, you have almost 100% 5-year survival rate. That drops sharply to about 16% when you talk about distant metastases. Interestingly, at the same time, while the incidence of melanoma increased over the past decades, also the 5-year survival increased over the past decades. And again, this might be because they get diagnosed earlier. Currently, we're at a 5-year survival rate for all stages of about 91%, and that has been pretty steady over the past few years. Now, how do you diagnose melanoma? Well, you take a biopsy and then you look at it. Now, the problem is that melanocytic lesions tend to have several criteria that can be overlapping in benign melanocytic lesions such as nevi and melanoma. Generally, there are certain morphologic criteria that point in the direction of melanoma. Those are general criteria like asymmetry and poor circumscription, prominent nucleoli, high nuclear cytoplasmic ratio, and variable melanin pigment. Importantly, in the epidermis, pagetoid spread. When you talk about the junction, conspicuous activity, pleomorphism, and mitotic activity are of concern. And in the dermis, mitotic activity, nodule formation, absence of maturation, pushing growth pattern, and spindle or epithelioid cells are also raising suspicion of a malignancy. Now, having said that, you can see a lot of these features also in benign nevi, as I mentioned before. An additional problem is that the Interobserver Agreement is actually not that particularly great when you talk about morphologic features of melanoma. We talked about circumscription, actually, so one would be perfect agreement between the participants in this study. And this actually included very prominent figures in the field of melanoma research, including Dr. Busam, Dr. Amin, and Dr. Barnhill. As you can see, for circumscription, it's less than 0.5, so just take that with a grain of salt. Now, I talked about that there are different entities. You have a wide range of histomorphologic features. So generally, we're talking about a histomorphologically and genetically diverse group. And the overlapping features with the benign entities don't make it much easier. So I'm trying to just illustrate that when you get a biopsy and you're trying to decide whether it's a benign lesion or melanoma, there has been a large gray zone that has been populated by various researchers in the past with interesting names, such as Maniac, which is the melanocytic acral nevus with intraepidermal ascending cells, atypical intraepithelial melanocytic proliferation, atypical Spitz tumor, melanocytic tumor of unknown malignant potential, and superficial atypical melanocytic tumors. Now, just to illustrate how difficult it can be, this is the first case that I brought, and this is basically a dead ringer. It's a large nodule with atypical melanocytes, with ulceration, prominent atypia, and mitotic activity, and I think no one would have any problem identifying this as a melanoma. Now, the case that I want to spend a little bit more time is the second case. Now, when you look at this case at low power, it looks relatively well circumscribed, and you can see that there's some relative maturation. It's probably not perfect, but there's some idea of maturation. But when you look at it closer, you actually start to see several features that are of concern. There's some pagetoid spread that you can appreciate. There's prominent pleomorphism. There are abundant mitotic figures in the dermal component. And at this point, you're kind of at a segue. What are you going to do with this? Are the benign features kind of overriding the malignant features? Are the malignant features more important than the benign features? And is there any way to discern that? So I went to the talk at the ASDP meeting, and I have to credit, I think, Dr. Jarami for this, although he used a different animal. But this is basically where you're at. So the question is, what's your diagnosis for this? So it could be a shark. Yeah, that's pretty obvious. That's a shark. But I'm no shark expert per se. Maybe it's just a dolphin. It would be really nice to just swim there and have something great to tell. But I'm not quite sure if it's one or the other. So maybe it's a dolphinoid shark. It could be an atypical aquatic creature, which would help no one. So you don't know if you should swim with it. It could be consistent with that. It could also be a shark-like animal of unknown biting potential. Or it could be a human with shark-like features. Now, this just to illustrate, it is not an easy decision that you're making. So the question is, you can either sit there at the slide and fight, and just call it something, be brave, and I heard a, to me, well-known cytopathologist say there's no bravery in cytopathology, there's no bravery in melanocytic lesions either. So, yeah, sure, you can just call it, if you want to take a wild guess, you can just run and call a friend or expert, or you can do some displacement activities like ice fishing or whatnot to just delay it. Now, in general, this is an important decision because it means peril to the patient no matter what you call it. So if you call it something benign, this can be bad because technically it could have been a malignant lesion, which should have been worked up differently. Or you call it something malignant, and let's say it's a lesion on the face, and this requires a drastic excision and additional morbidity associated with that. Nevertheless, I understand that this is the most important part of this, but it also means peril to the pathologist. Because in the end, lentiginous and litiginous, even though I heard that it's technically more litigious, is a very important problem, especially in dermatopathology. And those are figures that are unpublished by Dr. Tahan from a talk that he gave earlier this year. The industry that's associated with this is over 20 billion strong. And as sad as that is, only 20% of this money actually goes to patients for compensations afterwards. The rest stays with companies and lawyers and so forth. And importantly for this topic, they looked at different categories in the top 10 lawsuits in dermatopathology, and melanocytic neoplasms, whether it's a Spitz tumor or a Spitzoid melanoma and the like, actually make up about half of all the top 10 issues. Now, this is something that I have not verified, and I heard that by proxy. In the US, the consulted expert is not responsible for the diagnosis. So if you send a slide to an expert and the expert gives you an opinion about this lesion and this opinion is wrong in the end, you are still the one who signed the case and you're the one who's responsible. I heard that this is different in Canada, where the expert is actually the one who's then responsible, but just as a word of caution. I'm not entirely sure if this is really true, but so back to this. We're still trying to figure out where we're going to put this animal now. And so IHC doesn't really help that greatly in this. Yeah, you can do Ki-67 and see if there's an increased risk of activity, but in general, people try to go to molecular diagnostic aids, and it started basically with CGH, so comparative genomic hybridization, and then quickly turned into the application of FISH in this setting. Now, historically, CGH was originally described in 1992, and it's basically a method to detect and map DNA sequence copy number changes, and the principle is pretty straightforward. So you take tumor DNA and you label that in one particular color. Then you take a reference DNA, label that with a different color, and then hybridize that to a reference to a normal human chromosome. So basically what that means is if you label the tumor DNA in green, for example, if you have copy number gains, there's more green that's actually hybridizing with a normal DNA. So you have a green signal in this area, and conversely, if you have losses, you have more of the reference DNA showing through. Now, this was actually first applied by Bastian et al., who did probably most of the genetic work in melanoma in the past decades. And in 1998, they looked at 32 primary melanomas and did CGH on them. And what they found is the way that it's depicted here, so those are obviously the chromosomes, and the lines next to the chromosomes show gains or losses. If a line is to the left, then it shows losses. If it's to the right, it shows gains. And importantly here for chromosome 9 and 10, those thick lines actually are 10 cases for the one line, so it's not a single case. Now, they published that, and there was a very interesting finding because it was kind of the first idea that there could be some genetic aberration that could be employed for diagnostic purposes. And since they only had 32 melanomas, and as you can see, the melanoma is a relatively heterogeneous group, they continued on this path, and 5 years later then looked at different types of melanomas, compared different types of melanomas with each other, and melanomas with nevi. And this is basically the overall slide showing the gains that point upwards and the losses that point downwards, and compared to nevi. Now, this is a very laborious method, and time and technique has improved over the time. So now you don't really do chromosomal CGH anymore, you can do array CGH, but the principle is basically the same. So you again label normal and tumor DNA and hybridize that to a reference sequence. Now, this is all great, but the problem with this is that it's pretty labor and time intensive, it's expensive, and you cannot really have a morphologic correlate. So as you are aware of, the best thing to then do that is to move that over to a FISH assay. And so this is Jarami et al., but this is still the group of Boris Bastian. And what they did in 2009 is they developed one of the first FISH assays that has been widely used. Now, they were not the first ones. Moore et al. Were 1 year earlier. They used a different set of FISH probes, but this paper actually got a little bit more power behind it. And they had very good results with, so this is just the DAPI. Their probe set included the 11q13, the 6p, the 6 centromere, and the 6q. And the cyclin D1 is on 11q13, RAP1 on 6p, and MIB on 6q. Now, with this probe set, what they found in their set of 27 melanomas that they analyzed, if FISH was positive, and with FISH positive, I do not mean one single cell is positive. So they adjusted criteria, what the percentage is, for example, for gains in 6p in order to call that positive. And those vary depending on what kind of probe it was. But if they had the test positive, they actually could show that they could stratify the ambiguous tumors that they had into the ones that showed metastasis or the ones that did not. And this test has been in use for quite a while for histopathologically ambiguous tumors. Now, I'm going to talk about the caveats with this test and the follow-up FISH test in a second. But as it always is, the first study is great. It shows great results, and then people try to recapitulate that, and it actually doesn't turn out that great. Now, the problem is that this was only 27 melanomas, and you have different cohorts. If you look at different cohorts, you have different chromosomal aberrations that might not be detected with that. And some of the groups that looked at this assay either had similar results, some had pretty bad results with it. So in general, there was a consensus that this test has to be improved in terms of sensitivity, specificity, and also in terms of accuracy for classification. 3 years later, so 2012, this is relatively recent, they came up with a modified FISH assay. And in this study, again, it's Jarami's group, what they did here is they compared their old probe set to a new probe set that they developed and saw if there's improvement in the sensitivity and specificity. And just to illustrate some of the stains they did. So this is a Spitzoid melanoma, and for Spitzoid melanomas, actually they found that 9p21 deletion is actually a very good indicator. Now, don't be fooled by the arrows here. You see 2 copy numbers of 9p21 here, but those are actually background cells within the tumor cells. So the tumor cells are actually these, and they show homozygous loss of 9p21. So the final probe set that is currently in use now is the 6p25, which is still the RAP1, the 9p21 that I just showed you, which is CDK and 2A, 11q13, which is cyclin D1, and 8q24, which is MYC. So the main benefit of this assay, as you remember from the first assay, there were 6 probes on chromosome, I'm sorry, 3 probes on chromosome 6. The main advantage of this assay, first of all, is that you actually significantly decrease the susceptibility to false positives. Because if you're looking for chromosomal gains, you actually have to make sure that you don't look at just tetraploid cells. So if you have 3 of your 4 probes on one chromosome, it's relatively difficult to figure out whether it's just a tetraploid cell or not. In addition, the sensitivity and specificity in this validation cohort, and that's important, this validation cohort was 94 and 98%. Now, subsequent studies actually put the sensitivity probably more in the 80 to 85% range, and the specificity still is somewhere around 95%. But just to make sure that you understand, it's actually not 94% out in the wild. When they compared that to the probe set 1, they just found 75% sensitivity and 96% specificity. Now, the lower numbers here are actually because they have different cohorts that they looked at compared to the first study here. So the question is when to do FISH. You could just get any kind of nevus and you just do FISH with it. Other than that being wasteful, it's actually probably not very helpful either. Because in general, histologic examination remains the gold standard. And what FISH really is helpful for are histologically ambiguous lesions. Now, FISH doesn't come as a black and white result in that sense. It's a complex interpretation that is necessary, and you always have to keep in mind that false positives can occur because of tetraploidy. So the following are 2 relatively boring slides, but I'll walk you through them because they just illustrate how complex the actual evaluation of the FISH assay is. So, as I mentioned before, false positivity can occur due to tetraploidy, and that has been demonstrated in about 5 to 10% of Spitz nevi and about 14% of combined nevi with an epithelioid component. And if you remember, that was one of the features of malignancy as well. Now, there are criteria for false positivity, and here it gets really, really complicated. So what you basically have to have is over 30% of cells showing 3 or 4 copies with RED1, MIP, and cyclin D1. Okay? So 3 is because sometimes you basically chop part of the nucleus off and you just lose the fourth copy in it. But if you have 3 or 4 copies of all 3 in over 30% of the cells, this is considered a clear false positive. Now, there's a caveat to that. If you have all of this, but there's, okay, minus this, but there's MIP loss and or an increase of RED1 over SEP6, so the centromere probe for chromosome 6, or a 9p21 homozygous deletion, it's considered a true positive and not a false positive, okay? So now, this is all great for the over 30% tetraploid, but if tetraploidy is under 30% but over 10%, you have to get into even more muddy waters. Now, isolated 6q23 loss in atypical Spitzoid melanocytic tumors is actually something that has been described as more of a benign feature, actually, and some suggested to create basically an entity called atypical Spitz tumor with 6q23 deletion. Now, the second part of the areas of caution are more on the negative results. So negative results in severely atypical lesions where you have a consensus between pathologists that they are worried about malignancy in those cases also has to be taken with a grain of salt, because the false negative rate is also relatively high, and it's particularly high in intermittently sun-damaged skin and Spitzoid melanomas. So
those are cases where you should be doing FISH anyway, though, right?
So for Spitzoid melanomas, yes, you should. So if you have atypical Spitz tumor versus Spitzoid melanoma, yes, you could do FISH. And so you can for the intermittently sun-damaged skin. But I think the Spitzoid melanoma is probably the best application in these two. So, but bear in mind that if you have a histologic concern for malignancy and a negative FISH, still 15% are false negative in these cases. Now, for desmoplastic melanomas, and this is kind of where you're going, the sensitivity is about 50%, so it's kind of a coin toss, and do not send those for FISH. It's basically pointless. Now, in general, if you have negative FISH and a benign histology, this is very reassuring, and you can basically sign it off and sleep over it. Now, the important thing is that you have to consider cutoff values too. So I told you that there's a certain percentage of cells that need to show a gain or loss in order to be called positive or not. And currently for this assay, the majority are 29%. So if 29% show a gain in 11q, that would be considered positive. Now, if you have benign features and you just have 30% of positive cells, that is also something to be cautious about. Okay, so just consider that if you're close to the cutoff values and everything else speaks for something benign, be wary of that. Now, this is why I chose this case, because it exactly shows what the problem with the FISH assay is. So basically, the FISH assay in our case was negative. Now, there's one big caveat to that. So first of all, the FISH probe that was done was still the old probe. So we have not repeated the new probe for this, and I don't know if that would be any different. But as I mentioned, the sensitivity for lesions on intermittently sun-damaged skin is lower than on the sun-damaged skin. And since the consensus was that the morphologic features are actually concerning, this was actually signed out as a melanocytic tumor of uncertain malignant potential, at least, so a MELTUM, which still didn't help us that much in that sense. Now, let's switch gears to the third part of my talk. Let's say we figured out it's melanoma. Now, what do we do? Understanding the molecular pathways is actually very important for treatment purposes, because up until, as you can see, up until the early 2000s, the only two compounds that were actually approved by the FDA were dacarbazine and high-dose IL-2, and that was it. Now, let's go back a little bit further. The way that this targeted therapy kind of started accidentally was in 1976, when it was reported that estrogen receptor expression was present in melanoma. And about 16 years later, a group showed that there's a higher response rate of dacarbazine if you combine that with tamoxifen. Now, that actually really never got much traction, and couldn't be confirmed afterwards. But in general, if you understand the molecular pathways, you have a better grasp of what to target in this. And in 2002, along came BRAF. So the way that this actually started was that Davies et al. Looked at a whole array of cancer cell lines as well as a few primary tumors, and they sequenced BRAF. And what they found is highlighted here, that melanoma cancer cell lines actually showed okay, it's a little truncated over here. Melanoma cancer cell lines actually showed quite a high proportion of BRAF mutations, and so did the primary tumors. Now, what Davies et al. Also did is they looked at the kinase activity of the BRAF mutants, and as you can see here, the V600E, that's the V600E actually, has about a 15-fold increase over the regular BRAF. And conversely, when you look at downstream targets like ERK phosphorylation, you can see that the wild-type BRAF here has a much lower rate of ERK phosphorylation than the V600E. And this is independent of HRAS mutation. Now, what is BRAF? So BRAF is a 766 amino acid signal transduction serine threonine specific protein kinase, and it's part of the RAF kinase family. It actually has 3 conserved regions, one that binds RAS GTP and is self-regulatory. The second conserved region is the serine-rich hinge region, and the third region is the catalytic protein kinase region. Now, when it's active, BRAF forms dimers. So what does the V600E actually do? I showed you the results from Davies et al. A little bit earlier, but just to summarize, so BRAF V600E actually activates the downstream MAC pathway. With that, it evades senescence and apoptosis, and it leads to unchecked replicative potential. It also causes angiogenesis via MAC-dependent activation, and tissue invasion and metastasis, as well as evasion of the immune response. Now, just as a side note, and I'm not going to talk about that much, the V600E is also found in benign nephi, just for people who are not that familiar with it. Nevertheless, it has been something that has been heavily targeted in therapy for melanomas. And if you look at the MAP signaling cascade, this is basically where growth factors bind. That includes KIT. They activate RAS, which is also mutated in a large proportion of melanomas, which then conversely starts the BRAF-MEK phosphorylation cascade. And this actually leads to increased survival and cell proliferation. Now, aside of that, one other frequently mutated gene is P10, and P10 is involved in the PI3 kinase pathway. Here you again can see the MAP kinase pathway that I just illustrated. And this also leads to similar results, evading apoptosis and prolonged cell survival. A very recent discovery was actually the CDK4 pathway being targeted for therapy. And if you look at this pathway, I highlighted 3 areas here. That's the CDKN2A, the cyclin D, and the MYC. And if you remember from the FISH assay, those were actually all part of the FISH assay. Okay? But the CDK4 actually is involved in the retinoblastoma pathway as well. And a few months ago, it has been proposed to use that as a potential target in melanoma treatments as well. Now, as a quick summary, and it's important to note that this slide is from 2007. Okay, so in the past 5-6 years, a lot of things have happened. But in general, what this slides nicely illustrate are the different pathways: the MAP kinase pathway, the PI3 kinase pathway, and the cell cycle, and all the compounds that in 2007 were actually part of investigation and clinical trials. Now, those clinical trials, some of them actually are done, and I don't see it. No, that's not me. But several other ones have emerged in the meantime. Now, when you look at melanoma treatments, what I would like to talk about are not all of these several different compounds, but I'd like to focus on 3 main ones. That's first of all the BRAF-MEK pathway and the inhibitors, CTLA4 and PD1, just as a fun and interesting thing on the side. BRAF-MEK is by far the most important agents that we have right now. Now, I showed you this graph before. Up until about 2010, there was really not much going on in terms of pharmaceutical treatment. And then vemurafenib and ipilimumab were approved by the FDA. Shortly afterwards, dabrafenib and trametinib. This is all great stuff if you want to play Scrabble at some point. Nivolumab and lambrolizumab are, I think, approved as of now. And we're gonna start with BRAF inhibitors and then move on to the MEK inhibitors. Now, BRAF inhibitors started with sorafenib, and it's important to know that sorafenib didn't produce that great of a result, really, but sorafenib is actually a non-specific BRAF inhibitor. the big breakthrough kind of came with vemurafenib, and we're going to talk about those studies in a second. Recently approved, as you saw, dabrafenib and trametinib, and an important thing for especially dabrafenib is that was part of the BRAF study, is that it was also showing activity in patients with brain metastasis. And we're going to talk about the BRAF inhibitor resistance in a second, but it potentially abrogated that resistance. Importantly, BRAF mutations are not only the V600E, there are other mutations as well, and those are not as easily targeted by BRAF inhibitors. However, dabrafenib actually seemed to target those in some form as well. Now, as I said, sorafenib, it wasn't that great. It's non-selective, and basically what it does, it disables the kinase domain by locking the enzyme in an inactive form, and it's a pretty high affinity binding. Now, vemurafenib, this is just a nice structural formula, actually had their big study in 2011, which showed that when compared to dacarbazine, vemurafenib actually had an improved overall survival. If you look at 6 months, it's about 84% versus about 60%. And this held true for the subgroup analysis for most of the subgroups as well, with a few exceptions. Now, similarly, progression-free survival was significantly improved under vemurafenib as compared to dacarbazine. And the estimated median progression-free survival for vemurafenib was 5.3 months, while on dacarbazine it was just 1.6 months. Now, similarly, the subgroup analysis showed that this held true for almost all of the subgroups. What they also did is they looked at target lesions and looked if the lesions actually changed in size under both treatments. And what they showed is that the majority of lesions actually changed, a decrease in size under vemurafenib treatment, while there was kind of an even distribution in increase and decrease in size under dacarbazine. Now, this would all be fantastic, and this is what you read in the news, cancer is solved and everything's great. But the problem is that virtually everyone who actually gets BRAF inhibitors after a while develops resistance to the BRAF inhibitors. And there's a whole array of mechanisms that have been described in the meantime, how this acquired resistance actually takes place. So the first one is that, let me go back. So generally, as I said, the MAP kinase pathway should involve the growth factor receptor, RAS, BRAF, MEK. Now, if you take out BRAF here, what can happen is that you can have signaling through CRAF. You can have an alternate route of receptor tyrosine kinase signaling through the PI3 kinase pathway. You also can have NRAS mutations that kind of overcome the BRAF inhibition. Interestingly, some patients express truncated BRAF V600E variants, and those are not susceptible to the inhibitor. In addition, you can have downstream mutations of MEK, or just plain old BRAF V600E overexpression, or loss of NF1, which is an inhibitor of RAS. And lastly, there's an alternative MAP kinase activation through COT. So what people then did was looking at this pathway and saying, okay, well, we took out BRAF. There's somehow some downstream activation anyway, even if we take this out. So what if we take out BRAF and we take out something further downstream? So then they started treating with BRAF inhibitors and MEK inhibitors. And they actually had pretty nice success. This is a study by Flaherty et al. From MGH that was published in 2012, looking at monotherapy and two different types of combination of MEK and BRAF inhibitors. And as you can see, the progression-free survival is significantly improved under the combination therapy for both combinations, actually. And again, this holds true for the majority of the subgroups that were analyzed here. Now, Again, this would all be great and everything would be solved, but 2 weeks ago, and this is not in print yet, but EPUB, Weigel et al. Showed that MAP kinase pathway alterations in BRAF mutant melanoma patients with acquired resistance to combined RAF-MEK inhibition. So even if you combine those two, you still can develop further disease in the end. Now, just as a summary, again, this is a slide from 2011, so it's a little bit more up to date, but just to make you aware that it's actually, I don't want to make it sound like it's hopeless and all cancer will overcome whatever we throw at it, but in general, it's a very exciting phase for melanoma treatments, because the amount of clinical trials that are going on is pretty big, and a lot of them look very promising. So just to make you aware, currently there are a lot of targets that are, I'm kind of losing the pointer here, there are a lot of targets that are targeted, a lot of trials that are going on. And this is just a summary to put everyone to sleep. Now, we talked, I'm going to make this easy. We talked about everything over here. Okay, so everything in this right lower portion we did talk about for the most part. Now, this is all within the melanoma cell itself. Now, as you can see here, there's also the T cell and the dendritic cell, because there's an interaction with the immune system, which is actually pretty important in melanomas. And aside from targeting pathways within the melanoma cell, people have tried to actually target this particular area here as well recently. And in particular, PD-1 and CTLA-4 have been targeted. And just to briefly mention, CTLA-4, anti-cytotoxic T lymphocyte antigen 4, the drug is ipilimumab. This was approved by the FDA in 2011 for metastatic or unresectable melanoma. And what is important is it showed activity in melanoma, but the problem with this was that since it's not directly acting on the melanoma cell, actually the activity was somehow delayed, and that made it very difficult to pick it up with the usual measures that they have for the intracellular pathways. So what they basically suggested is a new method of looking at criteria to evaluate for efficacy in those. And they called it immune-related response criteria, which is basically just a new set of response criteria for immunotherapy because of the delay of this actual treatment. Now, if you look at the progression-free survival and overall survival with ipilimumab, you can see that it's significantly improved over just GP100. And lastly, the PD-1 anti-program DEath-1. There are basically two ways of, let me just go back to that. It's right over here. So this is the PD-1 receptor, and there are basically two ways of actually inhibiting that. You could either inhibit the PD-1 receptor itself, or you can try to tackle the PD-1 ligand, which is either PD-ligand 1 or PD-ligand 2. And the upregulated PD-1 expression on the tumor-infiltrating lymphocytes actually dampens T-cell activation. So you're trying to undampen the T-cell activation and therefore induce T-cell mediated apoptosis of the tumor cells. There are currently 3 agents that are being investigated, as far as I know, nivolumab, lambrozilumab. Those 2 have been approved by the FDA, and targeting ligand, which is MPDL3280A, by a to me unknown company. Now, in general, there's an unclear correlation if there's actually overexpression and response, because people looked at this and said, well, if you upregulate PD-1 expression on the tumor-infiltrating lymphocytes, you could actually predict already if the anti-PD-1 treatment would work, and that is not as straightforward as it seems. So you can't just throw a immunohistochemical stain at it and predict treatment response to this. So taking all of this together, in 2011, Wittwans et al. Basically kind of went the heme path route and proposed a molecular classification system for melanomas. And what they did is, and again, this is cut off here. So the types are basically, those are the detailed subtypes right here. And that goes from 1.1, 1.2, 1.3, 1.4 down to 5.1 on this slide. Those are the principal molecular subtypes. And they are divvied up by the pathways, the key gene biomarkers that are associated with it, and however you can diagnose those and what the potential relevant therapeutics are. So basically what they're trying to say is that after you diagnose that it's a melanoma, it would be helpful to basically subclassify it. I don't know if that really makes a big difference. And they have also secondary molecular subtypes, and those include actually the CGH or copy number / fish aberrations here. Now, again, this is our summary slide. The molecular biology of melanoma is pretty diverse. There are a lot of pathways that are involved. There are a lot of targets that are potentially exploited in here. And aside from it being clinically and histologically diverse, it's also molecularly diverse. And generally, it's a very interesting time based on the current research. Now, the main take-home messages from my talk that I would like you to have are that part A, no matter what the molecular means are, the histologic examination is still the gold standard. Okay. Fish can be helpful in ambiguous lesions. As I mentioned, there are a lot of areas of caution that you need to be aware of. And within the group of melanomas, there are several pathways that are involved, including, importantly, the MAP kinase pathway with BRAF. And the new treatment targeting of those pathways, new treatments that are targeting those pathways are emerging, and that includes the combined BRAF inhibitor and MEK inhibitor, as well as the CDK4, the PD-1, and the CTLA4. Now, those are my references, and with that, I thank you. Take any questions.
Thank you for that interesting talk. Melanoma immunotherapy was really hot a couple of years ago, and
Right.
Sort of hand in hand with that, there was also talk about hyperthermic therapy. Did we ever get anywhere with that?
That I honestly don't know. I think that the immunotherapy kind of went on the back burner with the recent MEK BRAF combined therapy, which is even better now. I'm not saying that you cannot combine all of those therapies after all, but I'm not quite sure about the hypothermic therapy.
It'd be nice to have a generalized solution instead of having to make a custom tumor vaccine.
Exactly, yeah. And especially if you cannot predict if someone would benefit from a certain treatment. So with the BRAF, it's relatively easy. You just sequence it, and then you can basically tell if someone's going to benefit from that. But with a PD-1, as I mentioned, if you cannot even tell by the expression profile on the lymphocytes whether a patient is benefiting from that therapy, you have no means of advising the clinician to actually start that therapy. So yeah, probably that might be interesting to just add.
Yeah, that's a hard, PD-1 is one of everybody with untreatable tumors wants to look at PD-1.
Yeah.
And it's the same question sitting in the pathology or the respiratory tumor group at the CALGB, and they want to do a trial of one of these PD-1 agents, but who they should put on it, or if they should have any selection at all, or whatever. It's an interesting question. There's no rational way, I think, of targeting.
Right. I mean, because basically you're not looking at a particular mutation that you want to target. You're basically just trying to modulate the immune system.
A large pathologist who also said there are no heroes in cytopathology, just lawsuits, has been known to say that immunostains are a lot like legal questions. You shouldn't answer you shouldn't ask questions to which you don't know the answer. It seems to me that fish falls into that same category.
Right.
If you don't really have a good, if your pretest predictive value is very low, you're going to get a lot of false positives.
That is correct, and that's why I mentioned all of these caveats, because it's very important. So basically what we have at our company is basically a algorithm if fish turns out this, and the number of tetraploid cells is this, and this is the feature, and the consensus that said this is what the final diagnosis will be. I mean, you have to be pretty clear and very consistent in how you interpret all of those results.
Are those numbers that need to be sort of validated for each laboratory in that maybe regional genetic or causation variants will give you a different
So
result, or is that just a number that any lab can set up?
No, you mean like the cutoff, whether it's positive or not? I think it slightly depends on how your lab runs the test, but overall they're pretty similar. I mean, I think that they recently, it used to be 29% for all 4 probes as a cutoff, and I think that they recently changed one of them to like 32%. But in the end, I mean, you're not changing absolute diagnoses. You're just moving entities from one probability to a different probability. You know, like basically. You get my?
Yeah.
Okay.
Thank you very much.
Thank you.